myself. Hi, I am Chiranjeev Rampal. I am the product manager for the AOSYS. And what is AOSYS is all about, I would like to give few PowerPoint presentations. And so AOSYS is a company from Ahmedabad who has been here in the industry for more than 3.5 years, and we are trying to innovate and do certain growth activities along with the to increase the vision in terms of future orthopedic and trauma and spinal products altogether. Our vision is to be clear, to be the leader in the medical technologies, where the innovation with a special focus on orthopedic and spinal and trauma products altogether. And we are committed to bring the innovation and meaningful solution and also take care of advanced spine care systems as well. So this is our organization, which we are from Ahmedabad itself, and we definitely, since we are an Indian company, it doesn't mean that we do not focus on the quality. Our quality is the must and foremost important parameters for us, and that's how we are also make in India. But definitely, we are also multinational companies who are present not only in India but also in Sri Lanka, Indonesia, Malaysia, and other global region as well in the Asian countries. And the not only in terms of implants, we are also focusing on the training and education activities. Like this webinar series is one of the series that we will be doing it, and slowly progressing the other parameters also. So this is a beginner, then we have intermediate, then we have advanced altogether, and we will be focusing also on to the bone model workshops and rest of the parameters. Okay. So key market trends that we have for AOS is like we are technology developed. So we have many machines and refineries coming from the Germany, and we have been and it's been on 24/7 to so that we can cater to the people need and the patient what do we say life like patient development as well. You can say that we also have an R&D in our factory itself in Ahmedabad, and we are definitely looking more have to be more patient centric organization. As I mentioned about the training and educational, we have also started conducting an observation program as well. Okay, so this observation program is nothing but if a young surgeon basically they usually would love to go and visit certain institute to develop and to enhance the skills and get a good gesture from the faculties who are being known in the India. Okay, like he was like Dr. Amit Jhala is there, Dr. Ayush Sharma is there, as today they are in the webinar series. But definitely this would also give us a platform where the intercity and interstate they can get connected to each and every surgeons and see their own setup of hospitals, the workflow in the operation theaters, how they are been how the patient has been maintained in the OPDs and every parameter. So as an AOSIS and as an art foundation program, we are trying to enhance this training educational to all the young surgeons in pan-India level basis as well. And also we have some international workshops also, which we do it. So that will be, will be in coming series as well. So this is all about our program and observation program shifts. Whereas for the today's webinar series, I'm very fortunate to gather all the respective faculties out here. And these are not only national but international faculties also. And with this, I would love to, give away the entire podium to the chairmanships today that we have it. Dr. Amit Jhala sir, Dr. Ayush Sharma, Dr. Shravin, Dr. Ankit, and the international faculties who has joined us from Sri Lanka as well. They are the most capable hands, and let me join, and everyone please help me and join in warmly welcoming the chairman, Dr. Amit Jhala sir, Dr. Ayush Sharma sir, and rest of the faculties. Thank you very much. Dr. Shravan, over to you. Dr. Shravan, you're on mute, sir.
Thank you so much for the introduction. I think this is one of the courses where, if you are you're doing a conventional open surgery and you want to transition from the open surgery to an MIS surgery, which is right now it is getting to the current standard of care for spine surgery. I think this is one of the courses to be in, because one of the major parts of not shifting to an MIS surgery is the initial hesitation, whether instrumentation is adequate, whether the decompression will be adequate, about the complications that arise. Everything can be now tackled through the tubular MIS procedures. So I think this is a great initiative by the AOSYS and Mr. Chiranjeev by for gathering such prestigious faculty like Jhala sir and Ayush Sharma sir. And I'm sure it's going to be a great series if we go once we go in a stepwise manner. So again, without further, uh, without much ado, we should just go ahead with today's talks.
That's great, sir.
Over to
So
you.
I would like to introduce our first the first session will be done by none other than Dr. Amit Jhala. Let me introduce Dr. Amit Jhala. He is basically the chairman for today's entire webinar series, and now everyone knows about him, not only in national and international internationally as well. His journey is being morely in evolutioning of the MI system, and he has witnessed his entire evolution and actively participated in the MIS, not only in MIS, also in OLIF, also in endoscopy. He has been an immediate past president of MISAP, that is the Minimally Invasive Spine Surgery Association of Bharat. It's a position that reflects the deep respect and trust his peers place in his leadership. He's also been a founding member of Endoscopy Spine Foundation of India, a key leader and faculty of the World Federation of Spinoscopy. So under his chairmanship today, we are in the most capable of hands. Ladies and gentlemen, please join me in warmly welcoming our chairman, Dr. Amit Jhala, sir.
Thank you, Chiranjeev, for a nice introduction.
Thank you.
I think this is a very nice concept and by which you have started this webinar series. And let me start my presentation. I'll just share my screen. Okay. Just check. Okay. Is it visible now?
Yes, sir. It's visible, sir.
Yes, yes. So I think what Chiranjeev told that it's always whenever we started my spine surgery as a career, it was all and all open spine surgeries. And from that, we have seen most of the evolution of how even the spine has developed and how the MIS has developed right from beginning of the MIS surgery. So what my intention is to take you through what is MIS, how it has evolved in spine surgery, and some philosophy of about the MIS tubular surgery and some nomenclatures. There are some confusing nomenclatures also. So I'll just take you through all this concept. I think it's a basic concept of or a philosophy of an MIS surgery on which I am going to talk about. So if you see in the field of medicine, this term MIS or minimally invasive surgery has taken over not only in spine surgery, but it has actually spine is the last section which has come where MIS has come. But it all started with other specialties like general surgery, neurosurgery, GI surgeries, even in orthopedic surgery, it was an arthroscopy. So, and even in cardiac surgery, it was just before a spine surgery. So spine surgery is lagging behind for minimally invasive, but that lagging behind is also now 25 years old. But let me take you to this concept. What is minimally invasive surgery? Now, if you see the concept of minimally invasive surgery, the term actually minimally invasive surgery was given by John Wickham, urologist from Britain in 1987. And he defined it as a minimal damage of biologic tissue at the point of entrance of surgical instruments. So the main concept given was that whenever you are operating, uh, any person you are operating, as minimum as possible if you disturb the biologic tissue at the point of entrance of the surgical instrument. So that was defined as the minimally invasive surgery for any of the specialty, and that was the term given by Wickham. Now, if you see the endoscopy from orthopedic sector, then though the term was given in 1987, I think Eugene Berger gave in 1921 did the first arthroscopy. So now if you see the arthroscopy, which was developed maybe around 25, 30 years back in the world, 30 years back. But the roots of these arthroscopy were maybe more than 80 years before then it was first popularized. So it is not a new concept. For anything, what we feel it is new, it's already done before 100 years. And that's what we have to see also. Now, if you see, that was the first arthroscopy. But if you see in 1987, Moret did the first laparoscopic cholecystectomy. And after that laparoscopic cholecystectomy, I think the endoscopic world has blown off in all the specialty. And you can see that the incision, which was very large, it is not about the incision which I'm going to talk about, but you can see it's a large incision to access the abdomen, and this was done by just puncture 2 or 3 puncture wounds to enter into the abdomen and do the first cholecystectomy. So that's how the minimally invasive surgery actually started developing after 1980s and 1987. Now coming to what is minimally invasive spine surgery. So coming to a specific topic on minimally invasive spine surgery. Now what is it? It leaves the smallest possible, the definition is leaves the smallest possible surgical footprint while attaining the same or better outcomes as those of traditional open spine surgery. So what does this mean? That if you are doing a traditional open surgery, then also you can do a minimally invasive surgery, because as small as possible surgical footprint you have, it is a relative term. So that is minimally invasive spine surgery, and how it has evolved, I'll just tell you. And the latest definition, which is given by the AO, is minimally invasive spine surgery can be defined as it's a suite of technology-dependent techniques. That means there is definitely a use of a technology and procedures that reduces local operative tissue damage. That means whenever we are operating, whatever collateral damage that we do has to be the least, and not only the least damage, but it has to influence the systemic effect on the patient. That means systemic surgical stress, enabling early return to function, striving for better outcomes than the traditional surgery. So it encompasses so many things. It encompasses the technology, it encompasses the reduced operative tissue damage, it encompasses while you are entering into the body, it should have a least surgical stress to the patient or to the body. And doing all these things, the patient should have an early return to function, and you should get the same outcomes or a better outcomes compared to the traditional techniques. So it encompasses so many things if you just look at this definition. So now when we say that MIS is better or MIS is compared to the traditional surgery, now what is a traditional surgery? I think this is also we should know what is a traditional surgery. Is there any definition that we know about a traditional surgery or a conventional surgery? So when we speak that we are doing a traditional surgery, we should understand what is a traditional surgery. So is there any definition? There is no definition of a traditional surgery. Can be identified, but never defined anywhere. So we should know that whatever we are talking about, MIS or a traditional surgery, they are all relative terms. So it is explained. It is not defined, but it is explained as the traditional approach and or dissection of any and all anatomical structures required by the operative surgeon in an open fashion, enabling him or her to identify all elements of surgical pathology in question and subsequently safely address that pathology with acceptable means of treatment, whether decompression, stabilization, reconstruction, or otherwise. That means whatever best way you identify the pathology and remove the pathology with less collateral damage, but an adequate exposure so that you are not damaging the important structures which are surrounding the pathology and which are normal, which are very, very important, like dura or nerve roots or anything. So this is relative. You can see that there is no definite guideline that what is a traditional surgery. Now, when we talk about the MIS surgery, what is MIS? I think this is very, very important because everyone I can see in the field of spine surgery that I can do this surgery with 8 millimeters of incision or maybe 15 millimeters of incision. So what is an MIS? Is 1 centimeter an MIS? Is 2 centimeter an MIS? Is 3 centimeter an MIS? I think we have to come out of this centimeter or a skin incisions that we are talking about. The basic aim of an MIS is not the skin incision. The basic aim of the MIS is a decreased collateral damage of the paraspinal muscles and use of natural anatomic planes decrease the muscle damage, and this is MIS surgery. So if you either make a port through the paraspinal muscles without damaging or minimally damaging them, or you go through the natural anatomic planes without damaging the muscles, this is an MIS for spine. So the basic important part is not the skin incision, which matters like 1 centimeter, 2 centimeter, or 3 centimeter, but the most important part is prevention of the damage to the paraspinal muscles. And therefore, the caveat comes, it is not incision, but the muscle damage, which is very, very important when you are going through the MIS surgery. I think these are the basic philosophy and principles that everyone should imbibe whenever we are doing a surgery. The important part is muscle damage and not the skin. So now what are the goals of traditional surgery? Are they different than MIS? No, they are not. The goals of the traditional surgery are same as MIS, and goals of the MIS surgery are same as the traditional surgery. So the ultimate end point that we have to reach either by an open, conventional, traditional, or an MIS has to be the same. If you have to do a fusion, you have to do a fusion. If you have to remove the disc, you have to remove the disc. Right. So if you want to decompress, you have to decompress. So the goal doesn't change. Only the change is in the approach, and for the approach is the protection of the paraspinal muscles, which is very, very important. So evolution of the approach with time, with improvement in skill and improvement in technology. So that collateral damage has improved with time and the skill of the surgeons. So whenever we were doing open surgeries, we are always cramped. When we shift from open surgeries to an MIS, we are cramped of the space. But as you learn this, there is improvement in the skill. And not only the skill improves, and that skill improves because of the technology which has come nowadays. In modern technology, you have everything which is available, and that enables the same goal with minimal minimal paraspinal damage. So that's very, very important. That goal doesn't change. It is with the help of improvement in the skill and improvement in the technology that we have now that we are able to do these MIS surgeries. And that's very, very, very important. Now, what are the metrics to suggest any procedure? Supposing how do you say that this procedure is an MIS procedure? This is absolutely a relative term, as I said. Basically, it is less invasive than others. If I say that if you are doing a micro discectomy, it is less invasive than open discectomy. If you say that I'm doing a tubular discectomy, it is less invasive compared to the micro discectomy. If I say that I'm doing an endoscopy, it is less invasive than the other. But that does not preclude that micro discectomy is not an MIS. Yes, it is also an MIS. But so there is no clear demarcation. It's a relative term. MIS is a relative term. But your intention and aim has to be as less surgical footprint as possible. And this is the basic crux of an MIS. Now, how do you define what are the parameters on which you can say that this is an MIS? So there are 4 parameters which are there. One is a local zone of injury. This is what I said, it's a collateral damage. So if you have a less local zone of injury when you are entering inside the body, that is one parameter. So this is what we are all talking about. But the other parameters are operative patient demographics. That means whenever you are entering, if the patient has less blood loss, less paraspinal muscle damage, they are directly dependent on the surgery and approach. So they are the operative patient demographics, like no blood loss, right? There are other parameters like hospitalization demographics. That means the patient can be up and about in maybe in 6-8 hours, and the patient can be discharged in the 24 hours. So they are hospital demographics, which also define that this is an MIS procedure. And the last and not but the least is the economics. So if it's an indirect way, but if you see that if you can discharge the patient early, then it decreases the cost of the hospitalization to the patient and indirectly affects the cost. So that also is an indirect way of defining or the parameters of an MIS. So these are the 4 parameters which are linked with an MIS, and you have to evaluate any procedure depending on these parameters. Just giving you the example of how the MIS tubular surgery or an MIS disc surgery has evolved. Now, if you see, it was in 1908, Feder Cross probably did the first successful removal of ruptured disc in history. And this is what is the same diagram of, this is how from the same article that I've taken, that this is the same picture that is depicted in 1908 article of Feder Cross. And you can see what he removed the disc. Then that was the first time that he did. And you can see that he did it in 1908, what we are talking today also. But it was done way back before 120 years probably. But what was the aim at that point? The aim was to remove the disc, and that was the goal of the surgery. But by doing that, it was a transdural. You can see that it was a transdural disc removal. So if you see, he opened the dura, he did a laminectomy, he removed the bone, he opened the dura, and then went anterior and removed the disc. So the aim was to remove the disc, but by reaching the disc, everything was damaged. You can see even the dura was opened up. Then in 1934, it was Mixter and Barr, and we all know about the Mixter and Barr. They were not the first, but they were the first publishers of their series of articles, a series of patients where they did a discectomy. But if you see them, they did the discectomy by not opening the dura, but they protected the dura. So the concept came here was not to open the dura, protect the dura, but to access and protect the dura and to reach to the disc, they removed the facet joints. Then in 1958, everyone knew that now this is not the way that we have to do. We have to even protect the facet joints because of the biomechanics evolution which was there. And therefore, in 1958, all the open procedures that we were doing is laminectomy, hemilaminectomy, fenestration, they were all started around 1958. So the concept came was minimal bone removal, but it was a wide muscle exposure. If you see these in 1950s or in our era when we started, it was a wide muscle exposure. So if you have a wide muscle exposure, there was no concept of the protection of the muscle, but the concept was to minimal bone damage. Then in 1974, McNabb came and gave the term laminectomy membrane. And this laminectomy membrane was very important to prevent the epidural fibrosis and minimum bone removal, but they also gave the term of reduced muscle scarring, because muscle scarring is very important, because if you have damaged muscle more, and they proved that 81% of the patients have a back stiffness, discomfort, or low back pain if you damage the muscle more, with longer rehabilitation time and loss of the muscle strength. So that's how they also gave the concept of not only limit the bony exposure, but also limit the muscle exposure. So this is the concept which came in 1977. And following the same concept, Yassergill, Kasper, and Wilson started the use of microscope. And microscope gave what? They limited not only the skin incision, but they limited the muscle scarring and epidural scarring, because you can see much more than doing an open surgery. And thus the patient had a less pain and early return to work. And they gave the concept of microdiscectomy in 1977. I think this was the first stage in 1977 when we started doing the concept of minimally invasive spine surgery. So that from there, the era of the minimally invasive spine surgery came. But parallel to that, Pervez Kambin also started with the concept of arthroscopic microdiscectomy, but it was not that much popularized. They went through the transforaminal endoscopy, which is very popular now as on today. Use the natural foramen to access the disc. It not only limited the skin, muscle, dura, and neural injuries, but the concept did not take up at that time because it was overtook by the all posterior approaches. In 1996, Yang, Rutten, and Hugland, they started not only the refinement of the transforaminal endoscopy, but they also started developing the interlaminar endoscopy. And this is what you can see, that the world over, everyone is moving towards the interlaminar endoscopy. So that came in 1996, but still that did not take in 1996. The era of endoscopy started, but it was always overtook by the use of an endoscope. with the tubular retractor. So they used endoscope. Professor Kevin Foley gave the concept in 1997 of a use of an endoscope with a tubular retractor. And that was the concept of microendoscopy, where they amalgamated the two things of an endoscope, which was already developing, as well as the tubular retractor. And they gave the concept of microendoscopic. And this revolutionized the MIS surgery from 1997. And this is what we are going to talk as on today. It limited everything: skin, muscle, epidural scarring, paraspinal muscles. And the era of MIS tubular spine surgery started since 2000, I would say. What I did was, my first microendoscopic discectomy that I did was in August 2002. That was nearly 5 years after that. Now, if you see as on today, tubular retractor is a versatile workhorse in spine surgery. More or less any type of surgery that you can do with the help of the tubular retractors. And that is not only the tubular retractor, it has developed and evolved. Whatever we did was in microendoscopy in 2002, it has evolved a lot now with the help of the technology. So it limits the skin incision and paraspinal muscle damage. There is no retraction of the muscle. But the concept given here was, it not only directly decreases the paraspinal muscle damage, but the iatrogenic ischemia, because of the retraction of the muscle that we were doing with the help of the retractors, did not denervate the paraspinal muscles, because we were never working around the paraspinal muscles. So it has multiple, no direct injury, no muscle damage because of the ischemic damage, no denervation of the paraspinal muscles. So it was the least damaging the paraspinal muscle. And that was the concept of the tubular retractor, on which the Professor Kevin Foley started. So it preserves the muscle strength, and you have all the other parameters which I said, very important, of less blood loss, post-op pain, decreased hospital stay, early rehabilitation. And most important is less fibrosis, so revisions were easy, and similar or better outcomes to open surgery. So these are all the big advantages of a tubular retractor surgery, which is a versatile, and we can do all the types of surgery. This is just an example that if you see, this is the fibrosis after a laminectomy, and this is just a fibrosis after a microendoscopic discectomy. You can see the surgical footprint, what we were talking about, is much, much less compared to the paraspinal muscle damage that was done by conventional, and this is through the tubular retractor. The important part of the tubular retraction approach is, compared to conventional surgery, this is a conventional approach where you have 8 to 10 centimeter incision. And if you want to reach the disc, which is about 8 millimeters, then still for removing the 8 millimeter of a disc, you have to do an 8 to 10 centimeters of an incision. While if you use tubular retractor, it is a reverse cone approach. That means you limit the skin incision as well as the muscle damage, but you do whatever is required inside. So this is known as a reverse cone approach. By wanding of the retractors, you are able to reach inferior parts, same level, upper part, and on the opposite side. So it is inside work we are doing the same. So that's why it is known as a reverse cone approach compared to the conventional approach that we have. Now, what is the rationale of tubular approach? This is also very, very important. If you see the traditional approach, we take an incision, we cut the skin, we cut this fascia, but we also detach these muscles attachment from the spinous process. So there is a detachment of the lumbodorsal fascia and paraspinal muscles. And when you detach these paraspinal muscles and you also retract, you definitely require a microscope or a loop or any type of magnification and light to retract these muscles. But what it happens is, when you complete your job, to reattach these paraspinal muscles to bone is not possible. You are just closing the skin, but the muscle never gets attached to the spinous process, or from where you have detached the spinal from the lamina and the spinous process. So muscle strength is definitely affected. While this is different in tubular approach, you don't detach the muscles from the bone. So the reattachment of the bone is very, very easy. You do a transmuscular tubular approach where you just dilate the muscles. That means you don't detach it from the bone. You make a skin incision, you make a facial incision, you dilate with the help of the dilators, which will be shown in the next by the next speakers. And then once you remove the tubular retractor, all the muscles come in place, and there is the muscles can be again having the same strength because you have not detached the insertion of these muscles. So that's very, very important. The only difficult part or different approach is that it is a targeted approach because you are going through the tube. So it is a non-extensile, and therefore there is a learning curve, and you have to have exact targeting of the pathology by looking at the MRI, you looking and extrapolating it to the to the to the X-rays and your three-dimensional imagination. So you have to target all these things because it's not a longitudinal approach, and you cannot extend it. So it is very, very important. Now I'll just go that this tubular retractor can be done in and out in any of the procedures, and this is what we are doing. Posterior approaches you can do in lumbar spine, thoracic spine, cervical spine. Even the anterior approaches that we are doing like Olive or the direct lateral approaches, they are all the extension of these tubular retractor approaches. So this is just this is a patient of a discectomy. You can do it. You can do a decompressions. I think the following speakers are going to talk on the discectomy and decompressions. So I'm not going to talk on these things. You can do a MIS procedure or an MIS fusions, and you can see this is the same multi-level, three small incisions, and you can do this approach. This is a patient of a tuberculosis in a thoracic spine, where just with the help of the tubular retractor, you can decompress the spinal cord and do a percutaneous fixation, and that's the fusion which also can be done in the thoracic spine by the posterolateral approaches. And not only there, but you can do in a cervical posterolateral posterior discectomy with the help of the tubular, which is very small tubular retractor approaches. So these are the applications. What just a small application that I have talked about, that it's a very versatile approach where you can do right from cervical, thoracic, and the lumbar region, all the pathologies. Not only that, the anterior approaches are also done by the tubular retractors, which may be Olive type of a retractor where you can just remove the pus and you can put the cage anterior, but it is all an MIS way. So that's the important. Now, what are the parametrics of the tubular surgery? As I said, that parametrics of the MIS I defined, but what is the parametrics of a tubular surgery? Parametrics means how it is different compared to the conventional. And this is what, if you see the size of the incision is very less. Denervation, there is no denervation of the muscles. If you see the inflammatory markers like CRP and IL-6 and other markers, definitely if you compare to the conventional CRP and IL-6 markers, they are much, much less. So there is no systemic effect also, or very less systemic effect, which is there by the MIS, and therefore it turns into the parametrics of that. Operative time, if you see more or less the operative time is same. MED, definitely it is much, 76 is too much. I think we can do it now this was in 2008 article, but now we can do it in maybe 30 minutes also, the MED. If you see the fluoroscopic time, definitely if you are doing an MIS TLIF compared to the conventional MIS TLIF, the fluoroscopist time is going to be more. But with the help of the navigation, I think that is also much more taken care of because we don't have to use much of a fluoro. Blood loss is also much less. Post-operative drainage is never required by doing a tubular compared to the conventional. If you see the post-op scenario, the vast post-op pain is equivocal, but the use of the post-op analgesics is much, much less with an MIS or tubular surgery. Time to ambulation is also much faster. In hospital stay, if you see all these parametrics, they are also much faster. So in all the parametrics that I told you for an MIS, I think tubular retractor scores over any of the conventional procedures that we are doing, and return to work is around 3 weeks. The only caveat is the radiation exposure if you are not using the navigation. So that's the only caveat, that you have to be very strict of the radiation exposure because fluoroscopic time is going to be high if you don't use the navigation. So that's where the only negative part, and the learning curve, definitely once you pass around 20 to 25 cases, the learning curve is going to be skipped. So in short, tubular MIS provides excellent surgical outcomes with equivalent surgical time and low complication rate as that of an open surgery. the tiny, invisible, cosmetically appealing scar. Initially, you feel that the scar is about 16 or 18 millimeters, but if you see the scar, it gets retracted. So if you see the patient after maybe 3 months or 6 months, you will never see the scar also. So cosmetically also it's appealing, reduced muscle dissection, denervation, and atrophy as compared to the open surgery. There is a reduced post-op pain, need for opioid, and the shorter duration of the use of the analgesics, reduced blood loss, no need for transfusion, quicker ambulation, shorter in-hospital stay, and early return to work. And there are significant, definitely, because the patient can be, of course, it can be done as an awake also, as well as the same day discharges are also possible with the tubular MIS surgeries. So now, if you see the types of tubular retractor, I'm not going to go into this detail because the next speaker is going to talk about it. But wide varieties of the tubular retractor now available, like non-expandable, static, and you can see different types of retractors which are there, which are available, and that has widened the use of the MIS. So, if you see the type of MIS procedure, what we are talking today is about the tubular, and the tubular retractors can be either static or an expandable. And compared to that, now again, we are also talking about the endoscope, which is also further narrowing the spectrum of an MIS, where you can do everything endoscopically as on today, either by the use of a monoportal or a biportal endoscopy. But there is in between also, there are certain procedures which we are doing is an endoscope assisted. Like initially we started with an endoscopic assisted MED procedure or microendoscopy, and that's how the name came. But as on today, we are doing sometimes an endo K-lift, where you are using an endoscope or a monoportal endoscope through the transforamen and using it for the fusion also. So there are certain procedures which are endoscope assisted. Sometimes you are using it for O-lift to remove the disc. So these are the ways in which you can amalgamate not only the tube, but you can use the tube along with the endoscope whenever you have a choice. So there is a wide array of technology which is now available, which is improving our results for the endoscopy. There are different nomenclatures. I don't think I'm going to go into the nomenclature much because each and every surgeon gives a different name, but more or less they are the same thing. What I am here, it is either an intralaminar or an extraforaminal. You can call it ULBD or an over the top, can call MIS TLIF, extraforaminal TLIF, anterior transpsoas, anterior to psoas or a transpsoas. And if you see, but they are doing the same discectomy, decompression, and fusion by different ways of approach, either by uniportal or biportal or a tubular. The only three procedures which are very, very important are discectomy, decompression, and fusion. So nomenclature can be anything, and there are so many nomenclatures given by the AO also, which I'm not going to go in detail of this, but these are the charts from the AO also. So the message is, it's a small incision, muscle preserving. It gives all the parameters for early rehab and early return to work. So it has evolved for a wide variety of indications now. It is not restrictive to only thing when it started of just doing a discectomy, and it has definite advantages over the open techniques. More you apply, more you learn, and you can just widen your indications depending on your learning curve of that stage. So tubular retractor is must to adopt for any spine surgeon who is starting their career in spine surgery. Thank you very much.
Thank you so much, sir, for the very wonderful talk. I think so. This is the entire history of the Open to MIS, and you have elaborately and in a very clear words, you have explained it in very much details. The point I like the most is like in 1997, we started the journey of the MIS, and I was just 6 years old or something like that. And we have come to a position where now endoscopy, KLIF, and we are doing the decompressions with the tubulars and other instrumentations as well. So thank you very much for your entire presentations. There's just one sincere request to all the viewers out there who have been logged in through the YouTube, Facebook, and Ortho TV. If you have any questions, any clarity to be given, there's a podium down there. Like there's a chat box. You can write in your entire details out there, and we will address it after this session. Okay, so if there is any basic questions, Dr. Sharvin, would you like to take the things up for the next lecture?
Yep, I think I'll start with my instrumentation talk, and then we can take the questions together for both.
Before you start, sir, let me introduce to the entire crowd about you. So Dr. Sharvin Seth has been here, and he is basically the one who is driving the entire webinar series with us, and I've been closely working with him. He's young, but he's very talented. I have been with him sitting and discussing the entire webinar series with him. So he has an expertise in endoscopy and minimally invasive spine surgeries. Not only he's restricted to this, but we have also seen posts on LinkedIn about his scoliosis and deformity cases as well. So he has been trained under some of the he has been trained by the finest spine surgeon in India, that is Dr. Amit Jhala sir, and he has been particularly passionate about minimally invasive techniques. He has not only been active in terms of in terms of surgery in surgeries or in the conferences also, but in practically he has published 13 papers in leading journals, including the Journal of Minimally Invasive Spine Surgeries and Indian Spinal Journal as well. Okay. He has also contributed chapters to major spine surgery textbook, including ASSI monogram on spine surgeries and the ASSI operation theater manually. So it's my privilege and honor to take the next lecture to be taken by none other than Dr. Sharvin Seth, sir. Thank you. Over to you, sir.
Thank you so much for the wonderful introduction.
Pleasure.
I'll share my screen. Is my presentation visible?
Yes, sir. You have to just put it in the preview. Thank
Okay.
you.
So after the elaborate talk by Jhala sir on the history of MIS and what the philosophy is, now we move on to what are the basic requirements for a minimally invasive tubular surgery. So the history, I was probably going to talk about the brief, but Jhala sir has given a very beautifully elaborated history of how the MIS surgery developed. So we know that MIS is not it's not a new guy in town. The MIS surgeries are going on since the 1930s and have developed drastically since then, right from microendoscopic discectomy to laminoplasty to intradiscal endoscopy. And then in 90s when the tubular decompression procedure started taking place. Now the tubular systems have advanced pretty far in terms of the technology of the tubular systems. Now we also get navigation systems in which the tubular systems are linked and they can be registered, and you can do a navigation guided docking, which eliminates the use of a CM. And to take it a notch further, we also have robotic assistance as well. So we'll start with the basic instruments. What we need first is a retractor system. The retractor system has to be good, it has to be sturdy and trustworthy. Because it is a very targeted approach. If the tubular retractor system is not sturdy, it keeps moving around, then we lose the target area, and that is when the trouble begins. So this is an image of a basic tubular retractor system, which consists of serial dilators right from the thinnest one as we go on dilating to the larger size. We can see here as well, it goes from 8 mm right to 22 mm. To keep the tubular retractor system sturdy, we need a flexible arm, which on tightening the screw becomes very rigid and keeps the tube in place. So it removes the need of handheld retractors or Taylor spike for the microdiscectomies as it was described before. The tubular systems also come in various depths to address the various phenotypes of the patients, right from the small tube of say 30 or 40 mm, and it goes up to almost 110 mm. So it can cover the entire spectrum, and this is one of the most basic requirements if you want to dive into minimally invasive spine surgery from conventional open surgery. Once we have the tubular retractor system in hand, so I'm going to show a short video of how this works. This is the first dilator which we have docked on which goes here. From the image on the top right, we can see the serial dilators that are in place in the target area. And once the tubular system is inserted and the flex arm is tightened, the tube stays there without the need to hold it there in place. So this is where a good, sturdy tubular retractor system is of extreme importance to make your surgery hassle-free. Once the tube is docked, this is the view from inside. We can see, as compared to a conventional open surgery, we can see that only a very specific target area of the spine is seen. As seen here, we can see some part of the lamina, the spinolaminar junction, and some part of the base of spinous process. Nothing else is in view. No other structures that we are not going to handle during surgery are seen. Coming to a different type of a tubular retractor system, this is what is a quadrant system, where it's an expandable type of a system where two arms of the tubular system can expand, giving you more space, and it allows insertion space for other two retractor blades, which can further dilate the space and make it larger. So for initial surgeries or for initial learning curve of this allows a much more space than a 22 millimeter of a static tubular retractor system. Once the tubular retractor system is in hand, next thing we need is illumination and magnification. Because unlike conventional surgeries, we do not have the OT lights which can target through a small tube. So which is why illumination is one of the most important requirements for a tubular MIS surgery. And then because it is a small area, we need good visualization and we need good magnification for exact identification of the structures, and most importantly, to avoid injury to the neural structures. So first is illumination through the tube. So most of the current tubular retractor systems, they have a small hole on the rim which is on the top, and from that rim a small fiber optic tube can be inserted inside, and that illuminates the entire area. The inner surface of these tubular retractor systems are reflective in such a way that the light bounces off and the target area is very well illuminated. Next in line is the surgical loops. So a lot of companies are making the surgical loops, which allow for illumination as well as magnification at the same time. These are very mobile, very flexible, easily accessible and available everywhere. The best part about this is you can use it and remove it as and when we want. That is number one. The other advantage is it allows for a lot more freedom around the operating area. A few disadvantages of the surgical loops are that it is not a static field. Like, it keeps moving with your head movement. So if the neck is not steady, the focal length, the zoom, the blurring keeps happening, which causes a lot of eye strain and a lot of neck strain. That is where the surgical microscopes have a huge advantage over the loops. They allow for much better magnification, visualization, and much better ergonomics as compared to the surgical loops. And now we have exoscopes which combine the both. So it removes the microscope, the huge cumbersome machine out of the way. There is a small tube which we can see here, which focuses on the tube and the area we want to see, and that is projected directly onto a large screen. With the help of 2D to 3D glasses, it also gives a 3D depth perception, and thus it leads to, again, even better ergonomics as compared to the microscope. Once we have all the basics in place, which is the tubular retractor system as well as the magnification in place, the next that comes is the specific or modified instrumentation, which will allow for a smooth and comfortable procedure steps. So again, this is a short video of all what instruments, how they differ from an conventional open surgery. So here we can see what it is. The video I've taken from a surgical microscope, we can see how nicely it has illuminated and magnified the view inside the tube. On this is what we have marked before, the spinous process. The right side of the screen is the caudal part, the left side is the cranial part, and below is the lateral. So very clearly we can see the bone, the lamina, the spinal, the interlaminar space, which is seen here. Once inside, we need to clear the soft tissue or the remaining muscles which are there just to make space on the bone, and which is why we need a long cautery point. A routine normal cautery point will not reach the space, and the cautery pencil might obstruct the view. So we need a nice long cautery point which goes inside and clears some of the residual fibers to allow good exposure of the bone. Next is the special dissectors which are available. So we know that dissectors are used in conventional open surgery to clear the ligamentum flavum from the inferior edge of the lamina, just to allow some space for our caries and rongers to enter inside. Similarly, these are also special. The dissectors are made in the same way. That will allow for clearance of the ligamentum flavum and for making some space for the next instrument to enter. These are the routine caries and rongers, but these are bayoneted. So bayoneted instruments allow for a better view, and the instrument is not in line with the lens of the microscope, which therefore there is no obstruction of the view, as we can see here. Once the lamina is cleared, we can very nicely see the neural structures. This is where the important other instrument is a retractor system, which also has a suction function. So the normal conventional open surgery suctions we use are cylindrical suctions with the suction part, the whole of the suction, which is only at the tip of the suction. But this instrument is flattened and it has a suction on the side. So it allows for some retraction of the nerve, while other sharper instruments or access to the disc can be made. So this allows for retraction of the neural structures, and we can see the disc inside, and we can do the discectomy or whatever procedure of fusion decompression that we have planned. For making an annulotomy cut, we have special bayoneted knives as well, because a straight knife will, again, the fingers, the knife handle obstruct the view, and therefore it is advisable to use a bayoneted knife to make the annulotomy to approach the disc space. And in the end, we have special ballpoint probes and hooks just to confirm the adequacy of our decompression, which can go along the nerve root, in the exiting foramen, the inferior or the superior part of the decompression. So to summarize, these are the basic instruments and the instrument trolley that is required for tubular MIS surgery. I'll go in a clockwise manner. As we can see here, the number one, which are bayoneted caries and rongers, as I've shown in the video. The handle is not in the line of work. So when we are working with the punch, this will not obstruct the view, and therefore it makes it a very safe instrument. We have disc forces which are long tipped, which are straight as well as forward going or upgoing discectomy forceps. This is a flex arm and the table mount, which will keep our tubular retractor in place. Now, this again is very important to have a good flex arm that will allow for a sturdy tube placement. Because what happens is, when we are angulating the instruments and there is some pressure on the tube, if the flex arm is not sturdy, the tube moves, the tube wands away, and it goes away from our direction of vision or where we want to work. And then again, we have to readjust, bring it back to place, confirm that we are in the same place, and it wastes a lot of time. we have a suction retractor. We can see the normal conventional open suction, which is cylindrical, and the suction retractor system, which is a flattened one with the suction hole on the side. The dissectors are also bayoneted, so when we are using it to retract the neural structures or to understand the anatomy in cases of any root anomalies, etc., again, it does not come in the way. And similarly, we have hooks and ballpoint probes, which are also bayoneted, which allow for checking of the adequacy of decompression, adequacy of the forearm anatomy, the mobility of the nerve roots, or to milk out the disc fragments, as the next speakers are going to demonstrate in their beautiful surgical videos how these instruments will be at work. Thank you so much.
Thank you, sir. Thank you for such a wonderful presentation about the instrumentation and the rest of the parameters. So before we set on to the next speaker, that will be Dr. Ayush Sharma, who will be taking up on the decompression and topics as well. In general, I had few questions. If you don't mind, can I address it to you and Dr. Amit Jhala, sir?
Sure.
Sure, you can do that.
That's great, sir. Thank you. Because there are a lot of chats which have been there on the YouTube. I'm having that, and they are just trying to understand, certain things. So, first, I'd like to start with you, sir, Amit, sir. So,
Yes.
in your entire experience, sir, there is always a hindrance. While you're moving from an open to an MI surgeries, you always mentioned there's a learning curve. But what was your biggest mindset that shifted you entirely from the open to MIs? Not entirely, in selective cases, from open to the MI, sir.
So I'll tell you very frankly, you see, when I was, I'm still young, but when I was much younger,
Correct, sir. So your video is not on, sir, if you don't mind.
so I'm just traveling, so you might see that I'm in the car, but
No worries.
no problem. But when I was very young, you see, I was doing my fellowship at a center. We were just doing large open surgeries, and they it was a very hi-fi center, and that was in 1998. That
Okay.
was in 1998, and in 1998 we got a surgeon with the same tubular retractor with an endoscope who came and demonstrated that surgery. So you
Oh.
see, whenever you are young with any newer technology, rather than older person fascinated, the younger surgeons are much more fascinated with the newer things, and this is what is going to evolve the science also. And as on today, you can see that younger surgeons are taking up more of the advanced techniques compared to the older surgeons who will sometimes have that plateau stage. So I was very much impressed with that system. The center where I was working, they did never picked up that. But then I was so much influenced with that this MIS system that I went for further training and all that, and I could convince myself because I was convinced that this is going to work. So the first thing for adoption of a new technique is you should be convinced yourself that no, this is the future or this is going to work in the future for the spine surgery. So you have to be a futuristic in your vision, and then only you can adopt a new technique. So that's how I adopted the new technique. But once you are into it, you will try to find out the ways and means how to adopt it to the different difficult challenges, and then try to overcome that challenges which come during your learning curve. But you have to be persistent and convinced about the procedure, right?
That's a great, sir. That's great, sir. So just one question I would like to ask you now, since you had this phase where you're young and you were doing the transition and someone gave an opportunity to do it. What about those surgeons who didn't had an opportunity to learn such phase at the young age, but right now they might hesitate to go into the MIs. So what will be your message and telling them out?
Where there is will, there is way. I don't see that there is no way anywhere. Actually speaking, in my era, there were very few opportunities. There was
Correct.
nothing like internet, nothing like that. I can go to YouTube, you Google, or no surgeons who are going to teach us. Now there are ample of opportunities. I can say that the world has moved so forward. It's so, even if you want to see any surgery by any surgeon in the world, it is on your mobile. It is on your mobile, and you can watch it. So it is your will and way that how you want to learn that technique. So there are a lot of opportunity. I don't see that today's young surgeon can say that we don't have that opportunity. I don't accept that thing.
Okay, so that's a good thing. Where the will, there is a way, definitely. And I think so. This should be the motto for the entire surgeons who would like to adopt the MIS as well. Sir, in one of your slide, I saw there were many MIS techniques which was collaborated. There were tubular, there is scalable, there's other parameters. How do you bifurcate while if a patient come and walk in, and he has some symptoms where the disc has been bulging out. So how do you prefer to which therapy you should adopt and take the things forward with the patient, sir?
See, there are different indications, and I am a person who would not stick with one particular technique. I will try to learn all the technique and then fit the technique to the pathology rather than to the pathology. So if I feel that this, so you have to learn all the technique. That's what my basic aim and motto is in my life. That I should not say that I'm an only endoscopic surgeon, or I am an only stental surgeon, or I am an only a monoportal surgeon. No, I don't want to stamp,
Mm-hmm.
because that will be a restrictive thing to treat the patient.
All right.
I might use any of these techniques which is best for the patient as well as in my hands. So both the
Okay.
things to be considered. So that's how I learn all the techniques. That's my philosophy.
That's great, sir. That's great, sir. So just one last question that is prompting in my head is that, every MIS, open surgery cannot be an MIS. And like, do you know how you will be able to segregate these parameters, overall? Or can MIS, all the open surgeries can be MIS? Or
Critically,
let me put this forward, like, will
yeah, so
MIS spine surgery eventually completely replace the open surgeries?
it
Or they will
cannot completely
coexist?
open. It cannot completely replace everyone. Everything has its own place. I don't say that open is going to be replaced by any means, because there are certain deformity. You cannot do it. It has to
Hmm.
be open only. So if you just talk about, if you see multi levels which can be, or some revisions which has to be done, you have to open the patient. If you have a fallback from your tubular or endoscope, you have to open the patient. So open surgery is the base. You should know completely the open surgery. Because if you are doing a reverse, that you learn endoscopy or you learn an tubular retractor, and if you have never seen an open surgery, you definitely will be in a problem sometimes in your life. If I have a dural tear, what will happen? I cannot do it with an endoscope or tube. I might have to open. So open surgery is going to stay. So it can never be replaced. So you have to learn the open surgery first and then evolve to the MIS, whatever way you want.
Got it, sir. Got it, sir. Dr. Shravan, sir, you have described us all about the instrumentations that we are using in the MIS, and since HCG being an institute like where you have been practicing, they are being well equipped with the instrumentations and with the microscope as well. Okay. Whereas those surgeons who are starting their practice and they still are yet to invest or have an inventory of all these instrumentation, what would be your key takeaway for them? So they start the MIS with those particular instrumentations as an hands-on.
Right. So that is a very good and important question. See, the everything that I've showed, all the instruments, all microscopes, they are all made by Indian companies as well, which are available at a very affordable rate. And I don't think that if you're beginning your journey as an MIS surgeon, you do not need a Zeiss microscope or a Medtronic or Globus sets, like, which are internationally recognized companies, which are extremely expensive. Uh, a good retractor system which consists of all of the tools is important. And as I said, I'm not saying it is as cheap as your conventional open surgeries, but if you want to learn a new technique, we need to invest both time and money. So that we have to get some basic instruments which have to be there. And if not all, if you ask the bare minimum which is required to start a tubular MIS surgery, tubular retractor system, magnification, and some form of instrument in the form of a Carrison and a discourse set. These are the basic instruments that are required. We may not need the entire array. Second, if the microscope is, if you're saying the microscope is not available or it is out of feasibility, this is where the surgical loops come in. So I also got surgical loops. I operated a few cases on them. Loops have a larger learning curve as compared to the microscope because the head keeps moving. We are not used to keeping a steady neck. There are neck problems. There is eye strain, especially if you have specs. It's a problem. You have to get those loops which lie on the spectator.
Yes, absolutely.
So of course, but then you have to stick to it. You cannot give up just because you don't have a particular resource. And right now, I think with the shipping routes and everything, all instruments are available everywhere. So it's just as Sir previously said, it's about intent. Ayush, sir, any thoughts from you regarding this? Like if yeah, you are also working in an institute and you have all the entire armamentarium of MIS surgeries, including endoscopes. So for somebody who is into a private kind of a setup, how to transition in terms of instruments?
You're asking me, Sharvin?
Yes, sir.
Yeah.
Yes.
So it's very funny. I'll tell you what do you think today. We have everything. I'll tell you how I started. When I started, we didn't have anything. So to do a tubular surgery, I used to order MI screws because we didn't have tubular set. So if they give me one tubular set for MI screws, I had to keep 3 cases, 2 tubular surgeries and 1 MIS TLIF. And this is how we started. And that scope was the loop. I started with loop and it was my own loop. And we made some modification to the in whatever we had, and this is how we started. It might look very we have everything in the world, but the story behind any startup is completely different ball game. So I still remember Medtronics, some depot used to have MI screws for 25,000 rupees those days. And we used to order them 4 screws for 1 lakh rupees and do 3 cases of two tubular discectomies and 1 TLIF. And that is the story before we somehow were able to manage a set of tubular system. And then now it's a different ball game. So so as I will agree, if you want to do it, you will find a way out of it. Buy, borrow, steal, and that is my motive. And if you want to do it, nothing in the world can stop you. So, that is how I'll place it.
Very well said. But in today's day and age, where I think, like Jhala sir also said, everything is readily available right at your fingertips. If you want to buy a new instrument, if you want to place an order.
Yeah. So more than even if you don't want to buy, talk to people like Chiranjeev. Do something. Tell them, okay, I want to
sure
learn it.
they also have a beautiful
there is a way out of
retractor
it.
set as well.
It is just you don't need to buy anything. The industry, if you order 1 case, you can get anything out of any industry, and you start from there. And when you make money or institutions starts believing in you, then you get the system, and that is how you start. But start.
So let's not get into those topics where we will be conveying the masses and my capex instrumentation going down. So absolutely, you're right, sir. This is the thing. But so there's one important question I would like to ask: how critical it will be for the choice of implant and the instruments? In terms of brand which you are using, does some instruments must be what we say, an international instruments, like, many multinational companies has it, or everything we can be localizing it to the Indian companies as well?
Comfort over cost is what I would say. If it's not about Indian or international companies, if the instruments are good, if you are comfortable with it, and if they are good in your hands, then I would select that company over the international companies. But as I said, comfort over cost. It's I would not say only this or only that. It can be a mix and match of both. It's all that way. Some instruments are better with the other companies, some are with some other companies. So it's you should not be rigid that I'll use only this, or I'll use only this technique, or I'll use only this approach. But some basic criteria should be followed. That, as I said, it should be sturdy, it should not move, it should not give me problems while I'm operating. So,
Dr. Ayush Sharma, sir, your opinion, sir?
So, I believe nowadays, if you choose a good company, so I'll tell you, when we started, especially for MIS, Indian companies were not that good in that era. But now they are as good as anyone. You choose a good company, and any company is fine until as long as they're using the good material. In terms of instrumentation, I'll tell you, it's a personal choice. I have the same lanky probe for last 12, 14 years. I know the weight even in my sleep. And I need that probe. Nothing else in the world works for me. Because, I have spent that 12 years with that probe. And, I still use that. No matter which company instrument I use, which screw I use, I have a set of my own instruments, which are there from the very beginning. And it is all about my comfort because of my ability to work with them, nothing to do with being company specific. So this is my take on this subject.
Great, sir. One last question before we get on to your lecture. Now, this is for, in fact, for everyone out there. I would like to have the opinion about it. Now, navigation and robotics are coming in between, and entering the MIS and even the open surgeries as well. What do you feel? And will the traditional open surgery of fluoroscopic instrumentation will be absoluted in the next decade?
the open surgery is never going to go obsolete. It is here to stay. So I think we should not put an expiry date on conventional open surgery.
Okay.
But having said that, I think any pathology, if you give any primary surgery, I think most of them can be managed in a minimally invasive manner, unless otherwise. Like, probably there are still a few set of surgeries which we might have to address in a conventional open manner. But with a lot of newer techniques and approaches and instrumentation that is available, I think, like, as I said, it is now becoming a standard of care. What conventional open discectomy, what was used to be a gold standard once, and right now we are doing even caudal equinus syndromes with endoscopic decompressions. So that is how it has evolved through the decades. So again, navigation does not change the approach. It is like it is a cherry on top of the cake. Of course, it has a lot of benefits, lot of, especially in MIS surgery, minimal radiation hazard, especially for us surgeons. We take so many shoots while putting screws. Especially if you are a beginner, you'll keep doing AP lateral, AP lateral. But of course, we have to learn on fluoroscopy first before even talking about navigation.
So your opinion, Amit sir, Ayush Sharma sir?
So I believe, see, these are the things for future. Just like, a C-arm, when it came, it was almost 50, 60 lakh rupees. The way things are going, they will become standard of care. Standard of care means you should have it.
Absolutely.
Having said that, I don't believe the technology will make bad surgeon good, but it will make good surgeon better. And this is how I will keep it.
That's great, sir. Amit sir, any of your opinion, sir? Since AI and robot is coming in, sir, since you have been practicing for more than 4 decades, 3 decades more. What is your take on
I
it?
feel that you see everything is very important. Technology is also, it has changed. You can see as on today also technology has changed the spine surgery gamut. everything is technology dependent now. And though navigation and I think that is going to stay. Everyone will have a navigation. As on today, because of the cost factor, it is not going to be. It is not by in each and every institution. But in next 10 years, I think that is going to be the standard of care. There is no doubt about it. Nobody can work without a navigation. But
If a lot of companies
like
start making it, I think that will make a
you have make in
lot.
India so many things coming, and it's not only now. Even the registration processes are going to change. It's not that it's only intraoperative CT that you require. I think there are so many other things which will come and help you out in this. So, and it will miniaturize. At present, if you just see the intraoperative CT scan which is available, it is
Yes.
all so bulky. So it has to miniaturize. So, and it is going to be there, and it will be affordable, and it will be a must. Like intraoperative neuromonitoring, we will not using it now. You see, some surgeries you cannot do it without it. So similarly, the patients will become so much aware that they will. It will be for everyone that it is required, not only for the patient safety but also for the surgeon stress. Both the things are so this is going to be the standard of care. I don't feel that the days are far enough where these technologies are going to be there.
Great, sir. Dr. Ankit, any of your opinion before we start with the next lecture? Sir, you're on mute, sir.
Oh,
Yes.
I think you should train in all new technology every time. With time,
That's
everything is needed. For standard
done,
of-
sir. Done, sir. So thank you. We'll just cut and short the Q&A session. Let's start with the next session. It will be by none other than Dr. Ayush Sharma, who is the co-chairman. And it's my privilege and honor to introduce him. Dr. Ayush Sharma has been the head of the spine surgery at Dr. Babasaheb Ambedkar Memorial Hospital, which is in Mumbai. And he's been equipped with this best equipments like in entire India. Okay. His institute has been referred to as a national institute around here, and he has been, I think so. He has done more than 12,000 cases, sir. If I'm by far right with the numbers.
I don't know. Sorry.
Fair enough. He's a true pioneer in minimal invasive surgeries. Dr. Sharma sir has been the first surgeon in Mumbai, one of the first surgeon who has been started in oblique lumbar interbody fusion, and even I remember I used to get scrubbed with him as well. And he has been there and he's been performing many MIS surgeries. So it's a pleasure to have you on this session, and I would love you to take this in the next session. Over to you, sir.
Thank you, Chiranjeev. So, I've been asked to talk about the tubular decompression and over the top tubular decompression, including the over the top technique. So, Dr. Shravan and Dr. Jhala sir has made my life very easy. But please understand, no matter what approach you use, the most important thing is to understand the patient and then select the correct procedure for the surgery. If you look at these two MRI, they look almost the same, but if you look closely, they are completely different entity. So if I have to do tubular surgeries for them, it will be completely different surgery altogether. While one you will add a decompression, the other one might need a fusion surgery because you can see there is a full facet signed and one of the facet has almost given away. So most important thing is to understand the correct patient and to target the correct patient before you get into doing the tubular decompression. As Shravan was talking about, you should have the system, no matter which system you choose, but you need a tubular system to do the surgery. So these are specific instrument which you should have so that you can perform the surgery. Magnification, as was discussed, is the key. Either you can use loop or you can use, microscope. I have worked with both. I started with loop and then slowly I migrated to microscope. You need certain MIS accessories. Like even if you look at these are bipolar cauteries. You need to have them bayoneted so that, you can work with them. You ideally will need a high-speed burr because that makes your life easy. You need some of these instruments, which again, has just been discussed. And of course, if you want to become a MIS surgeon, at least invest in a good imaging system. It might not be OARM 3D imaging, but at least a good 2D imaging system is paramount, because you don't have a visualization in this case. You rely on your imaging to understand where you are. So if you look at the tubular system, how it really works. So as it was discussed before, you have non-expandable, expandable, and quadrant system. So this is how the visualization and retraction differs. So what we are talking about is the tube which is in between, and it doesn't matter basically whether you are using expandable or a non-expandable one. The idea is to use this wisely. I prefer things depending upon the indication, not depending on the technology. I use everything. I am familiar with endoscope. I also do endoscopic decompression. I can do a open decompression. I use tubes. But having said that, tubes remains my favorite tool when it comes to decompression. I prefer, for discectomy, I have my other preferences. But when it comes to decompression, I'm very, very convinced the one of the most minimally invasive way to achieve a good decompression is through tubular retractor system. And that is my primary way to go when it comes to tubular retractor system. One of the unique things about, using decompression using a tubes is the contralateral decompression. And if I have just kept it out there so that you understand how it is being achieved. And of course, I'll show you in the video. So basically what you do is you use the same fixed point, but you tilt the table, tilt your microscope, and tilt the tube to even decompress the contralateral side or the opposite side. So although your incision remains the same, you are able to do a good ipsilateral with the decompression on the same side, and the contralateral decompression is the decompression on the opposite side. And this is the steps which you follow for that. And this is one of the beauty of the tubes, that just by changing the angle, you will be able to achieve it. So without any ado, let's look at the video. So this is a case of a patient who has a lumbar canal stenosis. You can see L4-5. There's significant stenosis. And this is, I have chosen a left-sided, approach. And if you look at, this is my docking. So, you need to dock what we call as a spinolaminar junction. So this is a spinolaminar junction. Basically, where you see the part of the lamina and part of the phlebum. So for docking for a tubular discectomy, or a decompression normally happens at a spinolaminar junction. And this is how you dock it. And of course, this is what you see here. I'm using a expandable tube, but it is not a quadrant. I prefer expandable tube without a quadrant system for these cases, especially the decompression, because it gives me a wider area and it makes my job faster. So it's just a preference. You can see this is the cranial part, this is the caudal part, this is the medial, and this is left lateral. If you look at how the expandable tubes are arranged here, it is different from the classical approach. My tubes are more mediolateral angled because I prefer this to achieve a better contralateral decompression when I use them. So the first step is to remove the muscles. This is just so that you can see the bone or the landmark. And this is what you see. This is what we will see, which is the lamina and the phlebum at the spinolaminar junction. Once I've identified it, I prefer a high-speed burr to do the ipsilateral laminectomy. So basically, use the burr and take out the lamina on your side. So this is what you are doing. So, I believe they are one of the safest way to do these surgeries. You take out the bone and you preserve the phlebum till you have done all your bony work. And that is how most of the surgeons prefer it. So the phlebum is the layer which will protect the dura. So till you are doing your bony work with this high-speed burrs, I prefer to protect keep the phlebum. So this is where if you look at the lamina, it will have outer cortex, an inner cortex. So now you can see the white shiny layer represents the inner cortex. And then, this is now I'm going towards the spinous process side. So I also, I exposed it. And now most of the bony work is done. You can see that there is a ligamentum flavum popping out. So now you know that you can now, I prefer doing the contralateral first. And as I told you, normally the idea is to keep the flavum intact, do your work, and then do the ligamentum flavum removal so that, your dura is protected. So once I have done the ipsilateral work, I am doing the contralateral. So I have just tilted the tubes and I am going to the opposite side and taking out the lamina on the opposite side. While the flavum is intact, it makes this surgery much more safer. And it comes with some amount of experience. If you want, you can check the C-arm or things like that. But normally, you know where you are depending. So if you can see, I have taken both the laminas out, and you can see sort of a V sort of a thing, where the only thing which is remaining is now the ligamentum flavum. So you can even take out the contralateral facets if they are impinging, depending upon what case you are dealing with. There are times where I sort of prefer a osteotome to do the removing the facet on the contralateral side. Now I am going more deep because you can see how the tubes have been tilted and how the table was tilted, so that you can see more on the opposite side. So as you tilt, you will be able to go more better on the contralateral side. And always it is better to finish the over the top decompression first. At least that's what I do, and then I come back to my side, which is the ipsilateral side. So this is where we are taking out undercutting the last part of the facet. So and especially if most of these cases, they don't only have a ligamentum flavum problem, but they also have a facetal impingement. So you can see the facet has been undercut, and the whole of the ligamentum flavum is with you. Maybe in this case, I want to do a bit more. So this is the contralateral facet being removed. And once you have done that, all that is remaining is the flavum. Now you can take them, at one go in block, what they call is a butterfly removal, or you can do piecemeal. Totally depends upon the case and depends upon on your patients. So now this is what is the flavectomy, where you take out the flavum. And at this stage you need to be a bit careful. Sometimes the flavum could be slightly adherent to the underlying dura, and this is the time, especially if you have very, very thick flavum, as you can see here, the dural tears are very, very common. So this is the step one should be a bit careful, because bony work normally is very, very safe. Now, if you can see, what I'm trying to do, once I got some space, I'm trying to protect the dura. I'm trying to push it away and make space on the opposite side first. So whichever side you choose, ensure that you do a good decompression on one side, so it gives you space to push the dura to the contralateral side, and then do the decompression on the contralateral side. So once you have done, once I have completed the decompression on one side, I'm going to the ipsilateral side. Of course, the contralateral decompression is not yet complete. You need to really check it and see that everything is done. So, but after doing quite a bit of decompression on the opposite side, I'm coming back to my side. And as you can see, I am trying to protect the dura all the time by pushing the dura and away from my rongers, so that you don't take the bite in the dura. Once you have done ipsilateral and the contralateral, you can go cranial and caudal and repeat the steps. The idea is to ensure that your dura is completely free. It is basically a decompression surgery, and decompression surgery means that you have achieved enough space for the cord and the root to relax. So this is the dura at the end of the decompression. As you can see, so if needed, you can even add a contralateral discectomy. I think there was some bleeding, so I put a gel foam or something out there. And if I want, we can add more to it. You can go cranial caudal You can look at the roots if you want to. This was just a phlegm from the posterior, which was the culprit. So in this case, we have done that. But this is another video. I'll just go quick. I think it has another. So here, if you see, the same steps are repeated, but if I think it's the same one or different one. Okay, I think so. Here, if here, what you can see, I think is the same video being repeated. Okay, so this is so not only that you can do a decompression, but if you need, you can look at the roots. You can, if you need, you can do a contralateral or an ipsilateral discectomy. As in this case, the same steps have been done. But after that, we thought that there's a bit of some amount of disc also there. So we were able to remove the disc. And once we have removed disc on one side, and this is the root, as you can see, it is completely free. And then you go to the contralateral side and not only do a decompression and remove the phlegm, just like we did in the previous case, you can, remove the disc on the contralateral side also. Just like the previous case, the trick is to tilt the tubes, ensure that you see the contralateral aspect. And here, because the patient not only had a neurological claudication, he also had a radiculopathy on both the side. So the idea was to not only decompress the dura, but to even look at the root. So when we looked at the root, we thought that there's small amount of some disc which is also compressing. So this you can look you can see how easy it is to look at the contralateral side. You can completely see the complete contralateral side, and even if needed, you can do a contralateral discectomy as is being done here from the same side. So in this case, so it is such a versatile approach. It totally depends upon the type of the patient portfolio you want to do. You want to do a simple decompression, you can remove only the ligamental phlegm. If you want to do a facetal release because the facets are the culprit, you can do that. If you want to do a decompression in terms of removing the disc as well, both on ipsilateral and contralateral side, you can do it, and you can see how easily the whole dura is being retracted. That means that contralateral decompression is complete, and you check that because in this specific case there was a radiculopathy as well. So you put the pen field and ensure that the roots are free. So I believe tubular approaches are one of the most versatile approaches which can be done. And this is the previous case. We can see there's a good decompression. And this is the beauty of the tubes. I believe, especially for decompression, they are one of the most minimally invasive technique. Look at the muscle mass. It is completely intact. Because you are dilating the muscles, you're not erasing anything. In most of the endoscopic technique as well, if you want to decompress, you need to erase quite a bit of muscle, and that is the problem with these technique. So in my book, in my hand, I prefer tubes when it comes to decompression because they are very versatile. You can do from discectomy to deformity correction, one technique if you learn. But whatever works best in your hand, you choose that technique. And don't be a fast surgeon. A fast surgeon doesn't mean the one who gets the job done earlier. But what it means is the one who gets his patient to work on his feet earliest. And for me, that is what MIS means. Thank you. Thank you so much.
Thank you.
Thank you so much, sir. Thank you so much. Before I think so, we'll take I have some couple of questions if you don't mind. May I
Yeah,
ask
sure.
you before you leave this session?
Yeah.
So you definitely talk about the contralateral side. You will do it first, and then you will move towards the to the on the same side itself. What will be your parameters or the tips and tricks that you don't get lost in the surgery, or where you are exactly?
So, initially, if you get lost, don't be shy to take shoots. I've taken enough shoots in my initial career because it is very easy to get lost, especially when you are a beginner. So there's no harm in just put the pen field wherever you think the structure is and get a shoot. Okay, and then you will know where you are, whether you're on a facet or you are somewhere else. So that is how it is. But normally, once you have done a couple of cases, now by looking at the structure, you will know where you are. So most of the surgeons who are experienced, they don't get lost in the contralateral aspect. But I will tell is, if you're a beginner, don't be shy of taking a Siam shoot.
Absolutely, sir. Absolutely. So one more question, if you don't mind. Uh, uh, if we consider intraoperatively, if you're doing a bilateral decompression, let's consider L4, L5 level, and how do you will determine interoperatively that you have achieved the maximum decompression and then you can come out of the surgery, sir?
So basically, the amount of decompression achieved totally depend upon the visualization, and that is one. And the second is the mobility of the dura and the nerve root. Normally, what a good decompressed dura will be, completely full. It will be like a tube, not like a balloon. And that itself tells you that your decompression is good. But even after that, normally what we'll do is we'll try to move the dura and see what is the mobility of the dura. If the mobility of the dura is good, that means it appears to be good, well decompressed. And especially if you have a radiculopathy insured, make sure that you check the roots as well, whether it's the ipsilateral root or the contralateral. As I showed in the second case, the patient also had a bilateral radiculopathy, where we went ahead and checked both the contralateral root, both the ipsilateral and contralateral roots as well, and that is how you ensure that you have achieved a good decompression. But I'll tell you one thing I have done initially in my career is also to get a post-op MRI. Although it might sound very stupid, but initial days I was very scared of contralateral decompression if I have done a good decompression, and they taught me a lot. And we could understand if I have done a maybe not a great decompression. Most of the time patients were good, but we knew that we were lacking in the decompression, and we sort of learned a lot from just doing the post-op MRIs, but that was a long time back.
Correct. I think that this is something that will haunt initially, like 2, 3 days will be involved and there will be canal stenosis and everything. Do you do the surgery in one sit or you do it on a stage-wise procedure, sir?
So multi-level surgeries are a very different ballgame. So it is something which you really have to understand. Most important is if you can identify where the pathology is coming from. One of the idea of MIS is to identify the culprit and only tackle that. You don't get lost with what is happening. But for whatever reason, see, if you cannot identify and you have to do quite a bit big surgery, then it up to 2 levels decompression is fine. Personally, I don't like doing more than 2-level decompression by tubes, especially when you have a big facet joint in some cases which are really impinging from the posterior. And that is my one indication for open surgery. And that is the only case I prefer still open, more than 3-level central decompression with big facet joint, because I believe the amount of efforts and the amount of time you take with MIS doing more than 3 levels is not worth it. And I believe it gives a equal result whether you choose open or MIS.
Okay. All right. So just one last question, which I would like to ask to entire faculty. Even we have surgeon and from international as well, Dr. Swarnakumaar. So this is dedicated to everyone. So how now, since you have a lot of experience, and definitely there will be instance where there will be an unexpected dural tear, usually happening over while we are doing a decompression and all those things. I know, Ayush sir, you are keeping the flavum intact, so this doesn't cause you much trouble, but sometimes it does. Like. So how do you tackle these situations, sir?
So dural tear even day before yesterday, we had a dural tear despite doing everything. And it was such a bad dural tear that there was no dura left to repair. Everything came out in one bite, the whole dura, and all the rootlets were out. So in spite of all the tips and tricks you do, there will be 1%, 2%. In our series, we have a 4% dual tear incidence, and we know what is it. But the good part about MIS is you really don't need to open in most of the times. What you need to do is ensure your rootlets go back. It was such a
Okay.
bad dural tear that I thought of opening it up, but I knew I cannot repair it. There's no dura left. The whole dura came in one bite. The whole thing was a vacuum. Only I could see rootlets. So in spite of my best judgment, I have no hesitation in opening it up. But I thought it's best not to open this one because even if I open, I cannot, repair it. We used a taco seal and, we put a
Go
cover
ahead.
all around it. But we ensured that rootlets went in. So that is one thing. If your rootlet doesn't go in, you cannot do that. And the beauty of the tube, again, and this patient just got discharged today, doing absolutely fine. The moment you remove the tubes, all the muscles, they simply fall back. And they take out your dead space for the CSF not to get collected. And these big dural tears somehow are more forgiving than the small dural tear, which has a lot of high pressure zone. So this is about the dural tear.
Yeah, that's my point of view from the beginning. We have been talking, we have been moving from the era of open surgery, from fenestration, loops, microscopic, and then in Sri Lanka, we have introduced endoscopy as well within this year. So the the beginners, they should be able to tackle the cases whenever there is a need. They have to open. They have to be passionate to do the open surgeries. That's an important key point. Even previously, Dr. Amit also emphasized that. So whatever the ways we are doing with MIS, as Dr. Ayush said, that dural tear is not uncommon. Even last week I had one dural tear, but I had to open and repair it. So during the endoscopic surgeries. So this is not uncommon. We must be very familiar with open surgery as well. MIS is not going to replace the open surgery totally. There are indications.
I think dural tear is one of the fearful complications at a beginner level, which keeps people away from tubular surgeries. Like if people want to try, they have a dural tear, they're like, no. The confidence goes away that it's a morale breaking thing. But I think as spine surgeons, we should not be afraid of dural tears. We have to be careful, extremely careful, to not to puncture the dura. But as sir also said that there is a 1 to 4% chance of a dural tear no matter how much care we take. So but that should not be a reason to shy away from learning tubular or MIS procedures. Is what I would say.
I think Dr. Amit, sir. Yes, sir. Please.
So if you are going to swim in a river, you should not be afraid of alligators. So if you are doing an MIS, or even if you are a spine surgeon by say, any spine surgeon should never be afraid of a dural tear. Then there is no right of you to become a spine surgeon. Right. So dural tear occurs. So that's not a big thing, and especially it is actually forgiving if you are doing an MIS tubular. In open, it may not be that much forgiving, but in MIS tubular, it is forgiving. And the third thing is that if you have a dural tear, you see, when you are in your early practice, you are afraid. And even your ego is very high that I am doing an MIS and I don't want to open. I want to finish the whole thing. I have told the patient that I'm not going to open. But you see, all these egos, you have to keep it aside. Our primary aim is to make the patient better. And that goal has to be kept in mind, whatever way, whether it's an open or an MIS. So that should not be any criteria. You see, dural tear occurs to anybody. As Ayush said, yeah, it occurs, anybody. Even today, I had a dural tear. So it occurs. So you should not be afraid of a dural tear. Right.
Great. Dr. Ankit, your views on this?
Yeah. So I always kept T-seal glue with me. Whenever dural tear occur, I put the nerve root inside the dural tube. I kept with muscle patch and T-seal always. Any surgery, I kept T-seal.
So you keep your backup ready. So
Yeah, definitely.
whenever instance there's such thing happen, which is very rare to occur, we have the armamentaries live with us. Great. Dr. Solangarachi, sir, who is also an international faculty who joined from Sri Lanka. Sir, your point of view on this?
Yeah, as I said, during, you mean that regarding the dual tear? What do you mean?
No, sir. I'm speaking with Dr. Solang Garachi, sir. Dr.
He's-
Chanaka, sir. He has also joined. He was also there, I think so. Yes. Okay, any which ways, I think so. He is not there. I'm so sorry. He just logged out. Fair enough, sir. I think so. Thank you. Thank you for your wonderful discussion, Dr. Ayush Sharma, sir. It was pleasure having you. I know you have to leave for an emergency case, and we will take it over, sir, from here. And I hope we can see you in the next series also. We will be happy, and we can, you can share us a wonderful cases because your center has been doing a lot of things, and new innovative instruments will be also coming up as well. So thank you for your time, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you very much. Over to the Dr. Ankit. I think so. I would like to introduce him first. Dr. Ankit has been traveling a fellowship in India's most prestigious institute, India's Spinal Surgery Center. He's been there. Gangaram Hospital, he's been there. Northern Railway Hospitals, he's been there, and many other institute as well. He's been practicing overall, and he's right now the I think so the one of the youngest surgeons who have adopted the MIS and has a good exposure overall together. Dr. Sharvin has been spoke highly about you while we are having the webinar sessions, and it's over to you, sir. Please take up the rest of the lecture, sir.
So thank you so much for AOSYS giving me such an opportunity. Thank you, Dr. Amit sir, Dr. Ayush sir, Dr. Sharvin, and international faculty. Thank you, Chiranjeevi. So I can share my screen.
Please do, sir.
Open that. It is visible?
1
No, sir,
minute,
not yet. Yes,
Dr. Chiranjeev, you say I'm running out of my battery of the laptop. So
All right, sir.
maybe I might it will just stop. But I'm still there till the time it works. Okay.
Sure, sir. Sure, sir. Thank you. Thank you, sir. Dr. Ankit, you can start the presentation, sir.
You're on mute.
Dr. Ankit, you're on mute, sir. So if you're trying to, can you stop the presentation and just go for the only viewing, not the screen, just the presentation only? It will be easy for you to address it via the while you're on mute also. So just go to the share screen, open it up. You will find two things. One, the entire screen, one will be application window. I request you to open the application window in which your presentation will be open.
This is not open.
It should. Yes, that's great. Thank you. So you're still on mute, sir. Poonam, can we unmute Dr. Ankit? Poonam?
Yes, sir, I'm trying.
Yes,
He's
please.
unmuted.
No, while he's sharing the screen, he's indirectly his entire presentation comes up, but he's getting muted.
Yes.
So audio mat karna, just put the presentation only. That's it. And no, it's still not happening, sir.
This is Windows sheet.
Just go to the share screen, open the application window that you have it. Okay, let's consider it's a PowerPoint presentation.
Yes.
And just share it. Do not use your video and something else.
So now I'm audible?
Yes, you're very much audible, sir.
Yeah.
Now you can go to the
Yes.
presentation.
Yes.
No,
Now it's fine?
I'm seeing your Google Sheet, sir. Sorry, the Google Chrome, but not the your presentation. So can you
You
just
can minimize this window and then start the presentation. I think that will
Okay.
problem is of shifting screens in
Now
no,
it's
I
audible?
think no, sir. The screen is not available. Now you have not actually done an entire screen. You have just put one Google screen. So can you cut the sharing again?
Yeah.
Cancel the sharing again? Yes.
Yes.
Again, do the same thing, but the PowerPoint presentation this time, sir, not the Google Sheet. Or
or you can share it to me. I can share from mine. You can ask me to pause and go forward.
It's not possible.
uh, so we have already done it, so not to worry. The same thing we have to do it again. Go to the share.
I do same thing, but this is not audible. Now skin is visible.
Not yet. Not yet. Okay, till the time I think so. You would be addressing the next lecture. Meantime, you just try and see. You can share it, or you can share it with me as well. We will take. Yes, now it's very
Yes.
much visible,
Now
and
is audible.
yes, you're audible as well.
Yeah.
Thank
Oh,
you.
sorry, much. So my talk is basically MIS tubular discectomy. Myself, Dr. Ankit Khodifad. So MIS tubular discectomy basically three type of retractor is the fixed quadrant, quadrant fixed tube. Any minimal invasive spine surgery, you need the wide illumination and magnification. So you should need a microscope or surgical loop. This is some special instrument you use in MIS surgery, like a long tip cautery, bioneted forceps, bioneted instrument. The easy the your surgery with bioneted instrument. The patient selection criteria same as conventional. Severe leg pain affecting the quality of life, neurological deficit, any coda equina syndrome, clinical radiological correlation is must. All type of discernation case can be done with MIS like paracentral, central, foraminal, extraforaminal, contained disc, sequestrated disc. Any type of disc herniation, any type of stenosis, any type of TLIP, you can deal with MIS surgery. Upmost priority is MRI surgery is planning. Planning according to your MRI picture and what is symptom. Like this is a superior migrated disc is different planning. This is a paracentral disc is different docking point. Either far lateral disc herniation is different docking point. So MRI surgery you should plan before the entering the surgery. Like most common is paracentral disc. So we discussed the today is paracentral disc. Like position of patient is prone position with horizontal posture. Keep the silicone jelly pad at the head and knee point. The landmark of any MIS tubular discectomy for central and paracentral disc herniation is 1.5 cm to 2 cm away from midline, and a dock on tube in interlaminar, half interlaminar window and half is lamina. This is how I mark in CM. I mark a spinal leader on lamina parallel to this face. Always this is the utmost important point. Your marking is parallel to this point. This is how mark, and then I put the incision. So incision is skin and fascia. You don't cut the muscle. So incision paraspinal 2 cm I always taken. Then I do subcutaneous bleeding using stop with monopolar or bipolar cautery. In initial phase, I always palpate the lamina, facet joint, medial facet joint. When you advance in MIS surgery, you can palpate with your first dilator also in MIS too. But in initial phase, you should palpate with finger for good feeling of lamina and facet joint. How we dock in MIS tubular, we take the one by one dilator and keep in lamina to dilate the muscle. This is how I docking the tube in any MIS surgery. This is the I dissect from muscle from lamina, and I do superior inferior scraping of the muscle for better view. This is how I dock the tube, and I attach with the table mounted rod. This is the initial view. This is the initial view. Any docking. This is how look in AP and lateral view in Siam. This is the lateral view. This is the lateral view. Your tube should be parallel to your disc face always, and as much as possible is flush to lamina, so muscle scraping is less. Your in APV you should dock in interlaminar window. This is one other method. If you do superior inferior medial lateral, this molding is there. So let's start with begin with a simple case example. 39-year male, acute leg pain since 2 months. Right SLR is positive, neurology is normal. This is a right paracentral disc herniation. So this is the appian lateral, how I mark the needle parallel to disc face, and in the docking of tube parallel to disc face. And this is a clinical picture of tube. Then starting of how I this is the initial picture. You should see in the muscle, then dissect from lamina. This is the lamina. This is the lamina. This is the phloem. You strip the phloem from lamina, and then you use the punch or high speed drill for laminotomy. This is the most important step whenever you do laminotomy and bleeding come out from a bony window. You should use the bone wax for controlling the bleeding. You just put the bone wax, bleeding is stopped. This is one of technique I control the bleeding with the bone wax. I put a bone wax to the lamina to stop the bleeding. Then is a free margin of phloem. I strip from superior margin of the phloem. Then I use the dissector for stripping of the phloem. I always do piecemeal phloectomy other than do end block or butterfly laminotomy. I always prefer piecemeal technique. Then I always dissect from lateral dura from phloem. Then I do phloetomy in lateral view. This is a cow punch. You should use the cow punch for below the phloem, under the lamina and under the facet joint. The bony work is required less, and heterogenic parts fracture is very rare if you are using the cow punch for forearm anatomy. So this is a final picture of forearm anatomy. You should see the disc in axilla. This is still I am doing forearm anatomy. This is the right side pathology. This is the left side pathology. That's why I kept the both video. This is the medial. This is the lateral. This is cranial line. This is a caudal line. In discectomy, I always use a punch other than a drill, and very tight synosis. Use a high speed drill for forearm anatomy. This is how look the phloem after the doing the foramen anatomy, complete foramen anatomy. This is a cleft. This is a medial cleft. Then I dissect from medial to lateral and superior to inferior, and I remove the phloem piecemeal manner. After doing the wide foraminotomy, I do discectomy. I use the suction dissection they mention in Sharvin in this for retraction of the cord and root, and then remove the disc piece by piece. I dissect now root from this was I remove the disc fragment. This is a very large disc fragment that don't come out in one fragment. So I remove this piecemeal. I retract now root from my suction dissector one side. I rarely use some now root retractor. I use always suction dissector for retracting the now root, and use the carry disc forceps for removing of disc. This was how I remove the disc fragment. The use fragment come. I never happy with one fragment. I always find the if another fragment is left or not, and then I find another big fragment. So never happy on one fragment. Always try to find out the other fragment and free now root. Otherwise, recurrence rate is higher. This is final decompression. I check for more another fragment or not. There is no another fragment. Now root is freely mobile and freely medialized. This is my endpoint of discectomy. If now root is easily mobile to medial and no free fragment in disc and underneath the phleum and posterior longitudinal ligament, and I check the foramen for probe if foramen is free. This is my endpoint of discectomy. I always check that way. This is one other fragment is came out. So I checking is utmost priority. This is final decompression. This is a no root free. Then I take the hose for if anything left out can come out. So in far lateral disc herniation, you should plan the according to your disc herniation. I plan the 4 centimeter away from midline and 1 centimeter away from the lateral margin of pedicle. Dock the tube at pars region and do the discectomy. Disc herniation adjacent to T-lip can also be possible with MIS surgery. MIS for recurrent disc herniation, I can use MIS retractor for recurrent disc herniation. Any massive disc herniation, I always use a MIS retractor, like tubular retractor, other than endoscopy. This was beauty of the MIS surgery. How you can do with loops also, and this is the beauty of the MIS surgery. If you remove the tube, all the muscle are fall back. This is the yeah. If you remove the you see the skin, you remove the tube, all the muscle are fall back into place. The minimal invasive spine surgery point to remember learning how begin with simple straightforward case. Keep tubular retractor parallel to dismus. For initial case, always check epi and lateral view. Tubular retractor position should be close as to the lamina as possible. Don't start fenestration till you identify the proper anatomy. Otherwise, you'll end up with used dural tear in lateral side. In redo case of any confusion, use epi and lateral well. If any individual durotomy, difficult to suture, I use always muscle patch and tissue glue ready. In my incision for this is already small, surgical time is very less, result are good. Why should I change? Incision remains same in obese, recurrent disc, far lateral disc herniation. Can deal with opposite side pathology as well. It is beginning of MIS journey, MIS tubular discectomy. It real benefit when is MIS TLIF, MIS decompression for canal stenosis, MIS cervical disc herniation, so on. On will, thank you so much.
Thank you, sir, for the wonderful presentation, giving us the good live demonstration that the people will be able to explore and even get through these videos. They will also learn certain few points as well. Before we get on to the next question, that will be mostly the session where we will be having a case discussion. There are some few questions, if you don't mind, can I ask you? These are the basic question, and any of the new surgeons would be, would love to understand about it. Now, since you have been started your MIS journey almost like I think so half a decade back or less than that as well. So, what common mistakes does the young surgeons basically do while they're doing the first tubular discectomy cases, sir? And how and what can they do to avoid them?
So, can I answer?
So it's for you only, sir.
Oh,
It's your
sorry.
it's you for you.
Sorry, sorry. The young surgeon, you always. In my initial career, I mistake docking very hard to into interlaminar window. First mistake I had taken that. Second is I start to less laminotomy. So I strip off the phleum during stripping of the phleum is the used dural depth. Second, I mistake make is a very inadequate fenestrated. Then I remove the disc first, then do phleum removal. They'll end up with a dural tear. So I think inadequate fenestration and start without doing proper fenestration foraminotomy. We're doing discectomy is the very hazardous for dural tear.
Okay. Dr. Shravan, sir, your take on this?
I think very beautifully demonstrated video of the discectomies and the steps. Most of the mistakes I think all of them I've also done in the initial part of my tubular practice. I think the first and the foremost thing I would point is wrong level, which happened to me, and I've been very confident. Yeah, I've reached the laminotomy is done, flavotomy is done, root is freed, I've reached the disc, and then you find out that it is not the correct level.
Oh.
I think this is also very important in different levels, because most of our disc prolapses are L4, 5, L5, S1. And we see a lot of L5 sacralizations, sometimes even S1 is lumbarized. And if we go through just through numerical marking, we might end up at the wrong level. So all our effort of the first 15, 20 minutes or the 45 minutes are waste. We have to do basically it's the entire surgery to be redone. So, and so wrong level is not, I mean, it is one of the things we should be careful about, especially that's what we should keep taking AP and lateral views. And second, I would say is for docking, I think to make the surgery comfortable, being parallel to the disc space is also of extreme importance. Because what happens is if we are not in line with the disc space, we keep struggling to enter the disc. The instruments keep hitting the tube, keep moving the tube, and it might end up with a dural tear. So this you should always square the disc space on the C-arm AP view. Tilt it one way or the other. Make sure the end plates of the disc space are dead parallel when we dock. And that is where we care careful about. I think dural tear and everything, we have done big dural tears, rootlets coming out. think we should it's a different topic entirely. Complications of tubular surgery is a entire, 2-hour talk by itself.
Correct, sir. Correct. Dr. Swarnakumaar, any thoughts upon this, sir?
Yeah, as we all discussed, I think we had to go in layer by layer before entering into the canal, the superficial layer of flaval dissection, and start with the bony dissection and go into the flaval dissection is the important key to avoid dural tear and approach the disc after having a clear view or in the fenestration. That's my key point in this discussion.
Great, sir. Great, sir. Great, sir. Dr. Ankit, I have seen in one of your videos, and you mentioned about it, that you always go for the second piece. So just wanted to understand your ideology behind it. Like, even if the main disc has been removed, you always find the second one. So what was the
So,
thought
some,
process behind it, sir?
so sometimes happen if you are remove the one piece and recurrence is within 2 to 3 days. So always check for complete discectomy and whatever fragment is come out, always remove all the disc, whichever fragment is come out. So I always check first, second, third piece till I get enough confident to I can done wide phenomenotomy and adequate discectomy. So I will check, repeat and repeat. And sometimes I found 2, 3, 4 fragment also.
Okay. So let's consider like in your experience, if there is there will be certain type of disc herniation, absolutely, and in which patient you will prefer to do an open instead of an MIS, sir?
Uh,
Or
uh,
have you classified it? Like if this certain type of disc herniation is there, then we will definitely we'll go for the open. Or if this has been there, like this BMIs, absolutely.
so I can do any disc with MI surgery, but in initial practice, what I always do in open and bilateral fenestrectomy and wide laminotomy. But nowadays I use the MIS tube for any disc herniation.
Okay. Sharvin sir,
We have
any
a
point of view?
few questions for all the faculties present.
Yeah.
So I would ask the senior level, what would be the first ideal case for a tubular discectomy? Now, if especially for beginners, if I want to gain more confidence that yes, I have successfully completed a tubular discectomy, that will encourage me to do more. Would be the first ideal case? So Jhala sir, Swarnakumaar sir, Ankit.
So, in my point of view, L5S1 with sequestered fragment is the ideal case to start the MIS surgery. One of the easiest case, and you can finish within the.
Yeah, the beginners, they should identify a big disc. What they say is easily as fenestrated disc, inferiorly migrated or superiorly migrated disc, they can easily identify and take it out. And big disc there to identify for the beginners.
I think very valid points made because L5S1 is a good level. It has a wide interlaminar window naturally, which is provided. So it has less bony work. We can start doing our discectomy work easy before we get the fatigue. Next is, do you always do a subtotal kind of a discectomy, or you just remove the free fragments and it's a targeted fragmentectomy kind of approach and then you're done with it?
There are different school of thoughts. One is to remove the whole disc, and the other one is to remove only the disc which is compressing. But in my practice, I do the which is part of the disc which is loose and it is compressing on the nerve root, and then I limit not to do that subtotal.
Right. And I think the one last I would have is epidural bleeding, because I remember I was horrified during my first initial cases when as soon as we retract the nerve root, there is a large epidural vessel which is popping. And if that goes ruptured, if we do not bipolar cauterize it in time, it just bleeds. And because of that narrow field of vision, it's very.
Hello.
Yeah, please go ahead.
Sorry.
No, so yes, any tips for the epidural bleeding for discectomy? Because that is one of the nightmares. Everything is done fine, and just as we are going to enter the disc, the vessel starts popping, and sometimes we are not even able to put the we're not able to stop the bleeding as in the initial learning curve. What is your experience with that?
So, Swarnakumaar sir, you are on mute, sir.
Yeah, it is starts with the positioning of the patient. They have to have a free abdominal movement to avoid any intra-abdominal pressure to cause this type of bleeding. That they have to be very careful when they position. Second, once they encounter the bleeding, they should not be panic. They have to wait. There's a natural stopping because of this clotting factors to work. They should not keep on sucking. They have to stop that and wait for a few minutes and then attempt to use the bipolar diathermy to stop the bleeding.
And I think I would summarize it with, so again, one last as like uh, remembering my own incident when in the initial part of the practice when we see the disc as a young surgeon we get excited that yes, and we start pulling on the fragment, but we have not done adequate milking out of the fragment, or it's just there, it's not able, it does not come out with 2 or 3 pulls, it's very tight. So any tips on how to manage that on milking out that large fragment that is stuck and it's not giving way with just pulling of the disc itself?
A blunt dissection around that mouth of the disc which is prolapsed. So it has to be dissected clearly before pulling it, because otherwise it might cause in piecemeal and we can miss the fragments which may be inside. The mouth has to be opened with blunt dissection, or even we can use a dissector to open the mouth to take out the disc. And again, the key is the tubular positioning parallel to the disc is very important in this type of situation. Otherwise, we can't widen the disc space and take out the disc part.
Thank you, sir. I think we can move on to the case presentation.
Absolutely, sir. So we have only a few
Right,
minutes
sir.
left with us. So let's discuss for a couple of minutes and then we can conclude the session. Let me take the privilege to introduce our next speaker, Dr. Swarnakumaar sir. He has actually held the highest leadership position in this field, and he has been the past president of Sri Lanka Orthopaedic Association and founder and a past president of Sri Lanka Hand Society. He has been pioneered the introduction of minimally invasive endoscopy spine surgery in Sri Lanka and have obtained his training from Germany. So this is all to you, sir. Swarnakumaar sir, please, over to you.
Yes, can you hear me?
Yes, sir, you're audible.
Yes, sir, we can hear you.
Okay, this case is bit partially irrelevant to this today's discussion, but anyway, this is one of the case I want to discuss. This is a 57-year-old doctor. He had a fall in May 24, and it was a fracture L1. It was managed conservatively by another station, and he presented to me after about around 6 to 8 weeks. The pain scale was 8 out of 10, and there was no neurological features, and his quality of work has been affected. He is unable to go for work. He is obese. His height was 170 centimeter. Weight is 128 kilogram. BMI is 40.8. There was tenderness on L1, and there was no neurological deficit. The X-ray shows there was a L1 fracture with MRI. There was no compression of the cord. This is the X-ray I show. You can see easily the L1 wedge fracture, which was causing painful movement. So what I did, this is the next important key point I want to emphasize. Flexion and extension view. It shows there's an opening of this wedge That means the fracture was not united over the period of 2 months. That was the reason he was in pain because of his comorbidities and obesity. And this is the MRI. It shows there is a fluid within the vertebral body that shows there's a non-union, and it is opening up with extension. So why surgery is indicated in this case? Because there is severe pain, instability, non-union, and though there was no neurology, I have to address it because of his pain. The challenges are obesity and he's diabetic with poor control. So what are the options we have? Because forget about this kyphoplasty, because this is a bit high-end. Whether to use kyphoplasty alone, vertebroplasty, kyphoplasty with stabilization, or vertebroplasty with stabilization. This was the option we had. Why I didn't consider open surgery was because of this obesity. So MIS is the important part in this type of managing these patients. He's a type 2 diabetic with poor control. And we don't want to have post-operative complications. So I decided to go for a MIS surgery and also to mobilize him as early as possible. So why kyphoplasty over vertebroplasty? Kyphoplasty, we can achieve the height, vertebroplasty, not. So why stabilization is in this patient important? Because of this obesity. It's a chronic injury over 2 months, and already it's non-union. So how many levels we have to stabilize? Usually we can stabilize with 1 level above and 1 level before, but because of his non-union and chronic pain over the last 2 months, I decided to go 2 level above, 2 level below, because it gives better stabilization. So this is the kyphoplasty, ended up with cementing. And this MIS screw fixation, I did 2 level above and 2 level below. And he was, this is a post-op X-ray. He was pain-free from next day. He was mobilized and sent home. Unfortunately, in 2 weeks, he called me. He had a fall in his washroom, and he came with pain. This X-ray, you can see there is pulling out of these screws from the proximal part. So what do I want to do? So there are 2 ways we could manage to revise and also manage conservatively. The patient and myself, we decided, okay, we'll manage conservatively and see. He was managed with brace, pain reduced over the period of a few weeks, and then he started going to work. And but he was with mild pain on and off. Follow-up X-ray. Within this week, I took an X-ray. It shows no further loosening during that period. And why didn't I revise at that? At the time was due to poor comorbidities, and he was able to tolerate that pain at the time. And considering the complications, I didn't do. This is a recent X-ray. Within a couple of days ago, I did a follow-up X-ray, and it shows there is a loosening of these proximal screws. We can see in this about T11 and T12 level. So what do I want to do now is another question. Anyway, I had to do an MRI to see the level of any compression, and I have to revise the surgery again. So my suggestions is revising the upper screws is paramount important, and I can go for a larger screws. It was a 5.5 screw earlier, but I would go for the larger screw. And I think I had to extend the level 1 level above with augmentation of screws with bond cement. So in this case, I consider all these 3 steps. So this is MIS screw fixation. It can cause this type of problems. But anyway, I open this for discussion from the faculty's point of view. We'll forget about the kyphoplasty part, but this screw fixation and how we can support this case.
It's a very well managed case, sir. As you rightly said, kyphoplasty we also don't routinely do in our practice. I would say more than it being a complex thing, cost factor is a major issue with kyphoplasty, and vertebroplasty gives almost more or less the same pain relief or the patient functional outcome if we
Yes.
leave radiology aside. So I would have also gone for the same thing as as you have described, vertebroplasty, but with fixation, because vertebroplasty alone, I reserve it only for very comorbid patients who are unfit for GA, who are ASA grade 4 or 5, who cannot withstand even some amount of general anesthesia. My fear with only vertebroplasty is the interface fracture, the cement which is very hard and the bone which is severely osteoporotic. If that goes for a non-union, that revision is a nightmare. To remove that cement mass, that
Yes.
level, that entire, it eventually turns out to be a corpectomy. So I think I would have done the same thing, vertebroplasty and MIS fixation.
So how about vertebral body augmentation and the sagittal balance with it? Like, if we are trying to do vertebral plasty, we are trying to see the size of the vertebral body is shrinking as of now. But in augmentation, we will be restoring its height, and the sagittal balance will be maintained of the patient.
So that is where the dynamic films come in. On extension film, we could see very nicely the vertebral body height getting restored up. And once that is restored, it falls in place. The sagittal balance is taken care of. The sagittal balance issue arises when the compression is, there is a severe height reduction, like almost 60, 70 degrees, and it does not open up. And usually, if you see, even in the elderly population, that sir and I think Ankit would have also come across in practice, lot of patients who have L5 S1 listhesis, that becomes symptomatic because of the compensatory hyperlordosis that happens there because of the hyperkyphosis at the fracture level, which has united but in kyphosis.
Yeah.
So the sagittal balance restoration would I would take into consideration, or even an aggressive procedure for that if there's a rigid kyphosis and it's not opening up that much. But with that much mobility, I think sagittal balance will take care of itself once we have put the screws and cement.
Okay, sir.
So this one, do you agree that I have to go one level above with augmentation of the screws and then stabilization of revising the screws proximal one?
Yes, absolutely. Like I said, I would have exactly managed it the same way. We had revised. I understand the complications that come with, obese patient revisions. We have to go open surgery because we cannot, find those even if the screw drops inside that fat mass. It's again, we have to find a lot of IITV shoots.
Yes.
But then sometimes it's like what has to be done has to be done. So again, extend one level, put larger screws. Probably, I think AOSYS has very good cement fenestrated screws.
Yes, I have used. They are very good.
So I would have put cement through the screw as well to increase the pull-out strength.
Yeah.
So one question from my end, do you consider doing the T-score value for each and every patient, or do you consider having only those vertebral compression fractures if you have into consideration, so that we can avoid these kind of situations altogether?
Sir,
can you repeat it?
So,
DEXA scan. You routinely do
DEXA scan, yes. Yeah. You routinely I do to assess their fragility situation. Yes.
Okay.
I think again there are two schools of thought in this. I know surgeons as like colleagues as well as senior surgeons who regularly do DEXA scans for all fixations.
Yes.
But we don't do it. We don't do DEXA scans at all.
Okay.
Usually severe osteoporosis, we can see on the X-ray that sir also showed, we can see osteoporosis pretty severe. The other thing is the DEXA score. It's a very good tool for patient counseling.
Okay.
And a medical legal impact. If why is this loosened? Because we have something documented.
Yeah.
But having said that, obviously in osteoporotic fractures, we are going to supplement and treat the main cause, which is osteoporosis. We have to give the teriparatide, denosumab, all the molecules. We are going to supplement that. The other question that arises with DEXA is the patient will repeat the DEXA, say 6 months later, and the value will probably show the same. It will show osteoporosis.
Yeah. But
It might have improved.
Yeah, usually they recommend to repeat after 2 years, not before that. That's the standard.
Absolutely. Patients will get the DEXA on their own because now it's very easily available. They'll go that now we have taken it for 6 months. Let's see what the DEXA has shown. And then again, there's an argument. It's very difficult to explain it to them that the bone quality will not become how it was, say, 30 years back, when they were young.
Yeah.
So, and it's not much of a surgical management guidance tool as it's there.
Yes.
Just for completion's sake.
All right, sir. I think so. We have. Yes, sir. Please.
Thank you so much for giving me these opportunities through AOSYS in this forum to discuss. And I gained a lot with your tubular dissection and these techniques and some videos. It was very useful. Thank you so much.
So we have already crossed the timing as well. So I would like to conclude this session entirely. Dr. Sharvin sir, any last thought? Or
No, I
any
think it has been
messages
a
that you have
wonderful
given to-
session. It has been a highly informative session, especially if you want to convert from conventional open to a tubular surgery. These are the first baby steps that are extremely important. And I think all the 4 talks today have covered everything that you need to know for the first leap into tubular surgeries. So yes, I would thank all the faculties, Jhala sir, Sharma sir, Swarnakumaar sir, Ankit, as well as Mr. Chiranjeev and AOSYS for setting this up and setting this academic tool, which we should take it further for everybody. It's a great initiative. Thank you so much.
Thank you, sir. Thank you.
so much.
Yes, Dr. Ankit. Any last words?
Thank you so much.
Thank you. So this is actually not the end of the series. All the viewers who are looking out there or who will be seeing it in the YouTube later on. So this is one of the web series that we have started on MIS, and it will be concluding. Not only will it be restricted to region wise, we will be going all through around the pan India level basis and having more number of faculties and more number of new faces with different case scenarios and discussions all together. So I request you to keep logged in. Check your Insta accounts, Ortho TV accounts, and rest of the AOSYS account as well, where you will getting the new insights and new helpful initiatives also. Last but not the least, I would like to thank the Ortho TV, Poonam, Gaurav, for helping us to conduct this entire webinar series very peacefully and very stressless at all, because the technical management was taken care by you guys. Thank you very much, sir, for your time, and thank you viewers for watching it out. See you next time.
Thank you so much. Thank you.
Thank you so much.
Thank you very much. Thank you. Thank you, Poonam.
Thank you, sir.
Thank you. Thank you for your time. Thank you. Have a good day. Bye. 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 Poonam, one request, do share the links with us once it get uploaded on the YouTube or the Ortho TV.
Sure, sir.
Sure. Thank you. And what was the maximum count that we have seen? So what the viewers?
251.
251. That's a great thing. Yeah. That's
Only on Ortho TV, not YouTube and Facebook.
Can
I
you
will
give
let
me
you
an
know
entire-
the count just now in 10 minutes.
Definitely. Thank you. Give me the entire agenda of YouTube and everything else as well.
Okay.
Okay.
Okay, sir.
Thank you. Have a good day. Thank you.